Today's topic is the current state of regenerative medicine in orthopedics, potential and pitfalls. Musculoskeletal pain and dysfunction attributable are a leading cause of physician visits, chronic pain, disability in the United States, with costs exceeding $1 trillion annually in the United States, so it's a big problem. And although the disease burden is high, the treatment options really remain limited. So enter orthobiologics. Orthobiologics are biological substances derived from the body or synthetic materials that are used to treat musculoskeletal disease and injury and disability, focusing on growth, replacement, and repair of tissue such as cartilage, tendons, ligaments, bones, muscle, and meniscus, which have really little intrinsic healing capacity unto themselves. So the potential application of regenerative therapies spans the breadth of orthopedics, using approaches such as cell transplantation, gene transfer, and other modalities that you'll hear about today. And although the basic science of orthobiologics suggests that they have great potential to promote healing of these tissues, the clinical evidence for benefit and risk has not really kept pace with the demand, which has been fueled really by the awareness and publicity around high-profile celebrities and athletes who have sought out these therapies. And that publicity, I think, combined with the limited efficacy, although it's growing, of conventional treatment options has led to unsubstantiated claims, I suppose, in direct-to-consumer advertising and widespread clinical use of unproven biologic therapies. So it's been a bit a controversial area. I think this has led to the demand and the generation of guidelines by numerous organizations, from the NIH to the National Academy of Sciences to AAOS, the American Academy of Orthopedic Surgeons, as well as many other sporting organizations. And so enter our special guest speaker today, who has actually authored and led many of these guidelines and position statements, Dr. Scott Rodeo. And Dr. Rodeo was actually himself a competitive athlete when he competed on the Stanford swimming team while completing his undergraduate studies there. So it's a great pleasure to have you here, Dr. Rodeo, and we look forward to your presentation.
Well, thank you. Thank you for the nice introduction. It's a pleasure to be here. And so, yes, I'm an orthopedic surgeon, and my clinical practice is sports medicine, but I also run a laboratory where we do some work in this whole area of kind of regenerative medicine. So I thought it'd be fun to go through kind of a little bit of the laboratory side as well as the clinical side of this area, because as a clinician scientist, my goal is to both carry out laboratory research, but importantly, translate that to patient care. So as mentioned there, this whole area of regenerative medicine certainly has tremendous potential, but it is an area that certainly needs further development. So let's just kind of jump right in here. Here are my disclosures. We have some support from various foundations, including the NIH, that supports a lot of our laboratory work, as well as some of our ongoing clinical trials. So what is regenerative medicine? I mean, this is essentially use of these so-called biologic augmentation techniques to improve tissue repair. And there are a number of different options we have available. Just to kind of set the stage here, there are various autologous blood products. Many of you may be familiar with the platelet-rich plasma. There is something called autologous conditioned serum. There are a number of other formulations, all derived from blood. Many of these work by inhibiting a number of inflammatory mediators. Some of these inhibit various matrix degrading enzymes like MMPs. So this blood products is one area. Obviously, cell therapy and stem cells. We're going to talk much more about kind of what really are stem cells here, but we can use cells derived from bone marrow or adipose tissue from a lipoaspiration, and even cells derived from various perinatal products, placenta, amnion, amniotic membrane, umbilical cord bloods. We can take these cells and do gene modification. There are some purified cytokines available in our field, in particular for bone formation. There are even scaffold materials that kind of fit in this whole rubric of orthobiologics, where we may combine cells or proteins with these materials. And lastly, even the ability to use commonly used FDA-approved drugs that can be repurposed in different areas that are found to actually affect musculoskeletal tissue, some of which are listed here at the bottom. So this gives you just a kind of 30,000-foot view of this whole area of regenerative medicine. We'll jump in here and talk more about specifically orthopedics. Certainly, this whole area has tremendous potential. I would suggest to you or submit to you that the clinical use of biologics has greatly outpaced the current both scientific and clinical evidence. And there are, frankly, a number of false claims for what are often unproven therapies. We see a lot of indiscriminate use in this area. There's a lot of aggressive marketing. If you follow this area, you've seen that the FDA has started to scrutinize many of these clinics that are using sometimes unproven therapies indiscriminately. Again, it's an area that has great potential, but certainly needs further development. My overall message, just to kind of frame this and to start with, is certainly techniques and methods to affect the biologic events in tissue repair, no doubt have tremendous potential. But again, I would submit to you are not really ready for prime time. In my own practice, we, as special surgery here, use these materials judiciously. I think there is a role for some of these autologous materials. And certainly preclinical animal studies suggest tremendous promise, but there are distinct limitations. As mentioned, we do see indiscriminate use of sometimes unproven therapies, and that actually may hinder progress in this whole field. Stem cells are certainly a good place to start. This whole area of regenerative medicine, one of the first things you think about is stem cells. So, but there's a lot of confusion as to really what truly is a stem cell. And I would pose the question: are there truly any stem cells available to us that we can use from adult tissues? So again, we can use cells derived from bone marrow, from fat, adipose tissue, and some of these perinatal sources. We often obtain bone marrow from iliac crest. We can do lipoaspirations from the buttock or abdomen. The basic universal stem cell criteria are as follows. These are, stem cell is a highly specialized cell by cellular and molecular criteria. These cells they're unspecialized, so they can develop into any of a number of cells. They can become a neuron or a cartilage cell or a bone cell or a liver cell. An important principle is self-renewal. We know the stem cells divide asymmetrically, which means they give rise to, like any cell gives rise to two distinct daughter cells, but one copy here remains as original stem cell, while the second cell goes on to become, pursue a non-stem cell fate. So this multipotent differentiation capacity kind of illustrated schematically in the bottom right here, where cell can go on, stem cell divide and renew itself. And so the population and the pool of stem cells remains, and or the cell can go on and differentiate into various tissues. I would submit to you that currently utilized cell sources contain few, if any, stem cells by formal criteria. We're going to go into that a little bit more here as we kind of move along here. Arnold Kaplan is an individual in our field who's credited with doing a lot of work in this area. It's a classic 1991 paper where started to define stem cells. But in fact, the concept of progenitor cells from bone marrow actually starts in the 1970s with Friedenstein and Owen. And then Arnold Kaplan in the early 1990s introduced this concept of MSCs, which you'll hear about, mesenchymal stem cells. And this is the classic rubric here seen on the upper right here. This is where these cells can become a number of different orthopedic related tissues: cartilage, tendon, ligament, muscle. In this concept, the progeny of a stem cell becomes committed to a specific phenotypic pathway, and it differentiates down into these cell types that you see listed here. And another kind of way to illustrate that here is how the stem cell can become these different tissues. And you see here the different signaling molecules that lead that cell to make that cell become either a bone cell or a cartilage cell or a tendon cell. And we know that both extrinsic factors, so local cues like these signaling molecules or the mechanical environment, combined with intrinsic factors, that is intrinsic, the cell machinery, the genetic makeup of that cell. These extrinsic and intrinsic factors interact at each stage during this lineage control to control both the rate and the characteristic phenotype of the cells that will emerge. So the biology is very complex. It's not just that cell and its genetics, but it's the environment that cell finds itself in. So Arnold Kaplan, back in the early 1990s, when he his seminal work, concluded that the isolation, mitotic expansion, and site-directed delivery of autologous stem cells can govern the rapid and specific repair of skeletal tissue. So that was pie in the sky, the idea that we can repair skeletal tissues or regenerate tissues. Well, moving forward around 2010, and then in another seminal paper in 2017, Arnold Kaplan kind of further developed this concept and became evident over the years that, in fact, the biologic effect of cells that we implant, whether these cells are from bone marrow or adipose or other sources, actually appears to be due to the production of anti-inflammatory and immune modulating mediators that will actually modify the local environment and affect local cells. In fact, that led Arnold Kaplan, to suggest changing the name from an MSC, from a mesenchymal stem cell, to a medicinal signaling cell, to more accurately reflect the fact that these cells, they localize at sites of injury or disease, and they secrete a number of bioactive factors that have anti-inflammatory properties. They're immune modulating. They can produce signaling molecules that are trophic and even regenerative. And he concluded, quote, "It is indeed the patient's own site-specific and tissue-specific resident stem cells that construct the new tissue as stimulated by the bioactive factors secreted by these cells." So concept here being that the cells we put in, these quote unquote stem cells, actually work via a paracrine mechanism by producing these various signaling molecules. So it's become evident that exogenous cells that we implant may in fact function by modifying the injury environment rather than directly contributing to healing. These cells may be symptom modifying, but really very little evidence to suggest that they are truly structure modifying. And I'm going to talk more about this concept as we go along here. The cells we implant probably work by stimulating the intrinsic stem cell niche that we know exists in many tissues. So further to this concept, so the cells, if they're producing these signaling molecules, these signaling molecules are contained in exosomes. Exosomes are extracellular vesicles that are released from inside the cell when a multivesicular body fuses with the cell membrane. And essentially, it releases the cell cargo, if you will, and that may contain lipids and microRNAs and various proteins. The concept here is if we can collect exosomes, we could obtain the benefits of cell therapy without all of the logistical issues that are related to cell culturing, cell expansion, cell processing, transportation, all of those factors there. In fact, we know that exosomes, these bodies derived from cells, can induce polarization of macrophages into more of a pro-regenerative kind of phenotype here. We'll talk more about that as well. But these exosomes can certainly push some of these immune cells to contribute to their anti-inflammatory and immunomodulatory properties. We'll go into that as we kind of move along here. So again, what cells are we talking about when we talk about, quote unquote stem cells or MSCs? Well, classic paper from the International Society for Cell and Gene Therapy kind of laid out the basic criteria for an MSC. And again, it's important to note that the S is stromal cell. Really not, it's not a mesenchymal stem cell. These are mesenchymal stromal cells. And these are defined by 3 criteria. These cells need to be plastic adherent when they're maintained in standard culture. So they adhere to tissue culture plastic. They express a certain repertoire of cell surface molecules listed here, not to get into all the details, but there are certain markers that are positive and certain that have to be negative. And of course, these cells must differentiate into various phenotypes, in particular, osteoblasts, bone cells, adipocytes, fat cells, and cartilage cells in vitro. So these are the basic criteria by which MSCs are defined. And so keep this in mind as we talk about the cells that we as clinicians can use. Better term for us to use, it's become evident, is connective tissue progenitors. This is a heterogeneous population of tissue resident cells that can in fact proliferate and generate progeny. And they do have the capacity to differentiate into various connective tissues, but in a more restricted fashion than a true stem cell. So a better term for us to use in all of these cells that we use is the connective tissue progenitor. And these cells can be demonstrated by the ability to form colonies in units. So we can form colony forming units as a measure of connective tissue progenitor cells. And so given this term MSC should really only be used to refer to a culture expanded population of cells that meet these criteria from the International Society for Cell Therapy. And this term should not be used to describe these heterogeneous populations of native cells with really undefined properties in vivo. So the cells that we use from bone marrow, from adipose tissue, really should not be truly called an MSC. So again, back clinically, what options do we have as clinicians? Well, we can, again, obtain cells from bone marrow, whether the iliac crest, or here's a picture with the needle in the distal femur during an arthroscopic knee procedure. Now, the majority of stem cells, if you will, or progenitor cells in bone marrow, are actually hematopoietic stem cells. These are cells that form the blood elements. That's not what we want for these orthopedic tissues. We want the mesenchymal cells. Well, the number of true stem cells in bone marrow by any criteria is really vanishingly few. Maybe 1 in 10,000 cells in bone marrow are true stromal cells by any definition. Now we can obtain cells, as mentioned, from fat, from adipose tissue. We can do a lipoaspiration. There's different formulations we use clinically. One is a microfragmented fat, taking fat and essentially using emulsification to kind of break down the fat. And when that does, it kind of liberates some cells. Beyond that, we can obtain the stromal vascular fraction, which is basically taking fat and processing this with enzymes. The enzymatic digestion lets us liberate many, many more cells, but still we have a very heterogeneous population of cells. There are some adipose stromal cells, but there's a number of endothelial cells and red cells and lymphocytes and other immune cells in these formulations. A further refinement is adipose derived stromal cells, but this requires culture expansion. So this is taking fat, we can break it down with enzymes, but then we go ahead and take that and culture that in the laboratory. And these cells can then differentiate into these various lineages. Well, understand that we as clinicians can't take these cells out of the operating room or clinic and do ex vivo manipulation. That's not currently allowed by the FDA. So this culture expansion can only be done in the setting of a clinical trial. I mentioned briefly that there are these perinatal products that are available. Human amniotic membrane derived products are available. These certainly are a source of various antifibrotic and anti-inflammatory cytokines and immune modulating proteins. But it's become clear that there are very few, if any, true cells or viable cells in these materials, and essentially no true stem cells by any criteria. Very little controlled human data at this time, but these have been used and then they've been marketed heavily. It's a whole area, as mentioned, there's really aggressive marketing has been one of the driving factors in this whole area here. In addition to amniotic membrane derived materials, cells can be and have been used from umbilical cord bloods and placental tissues. But importantly, these formulations now can only be used in an FDA approved clinical trial. That's based on some of the basic tenets of the rules from the FDA, one of which is that if the product relies on live cells, which these products they purport to, even though they probably don't, they are advertised as such. Because of that, they need to be done only in a clinical trial. So really, we can't use these perinatal products on any regular basis at this time. I'm going to distinguish exogenous cells from, again, intrinsic stem cells. I mentioned briefly. So again, we can use cells from marrow, from adipose tissue, the perinatal tissues. In contrast, we'll talk a little bit about intrinsic stem cells. We know there is a niche of cells lining the walls of blood vessels, called pericyte cells, that they have some ability to regenerate tissues. And it may be that the cells we implant from bone marrow or adipose on the left side of the slide actually stimulates these intrinsic stem cells. And that's what really leads to the activity. And we'll get into that a little bit more as we move along here with these concepts as well. When we do put cells in, how do they work? What happens? Well, it's clear that these cells can be symptom modifying. Again, as mentioned, they work via a paracrine mechanism by producing various anti-inflammatory mediators, various immune modulating proteins. And the likely mechanisms they act upon local tissue cells and maybe even distant cells to modulate the local immune environment, and thus can, in fact, impact symptoms. The next kind of frontier and wish is, can they be structure modifying? That is, can they lead to true tissue regeneration? Well, I'll say right here, there's very little data to suggest on any regular basis that we can truly regenerate tissue. But the goal would be, if the cells we put in can act upon the local tissues, to truly induce tissue regeneration. I'd submit to you that we currently have essentially zero ability to use quote unquote stem cells in our practices. Now, as mentioned, the number of true stem cells by any cellular, molecular, or functional criteria in these currently used formulations is really quite, vanishingly small. As mentioned, the classic definition of an MSC is based on culture expanded cells. Well, that's very different than the cells that we can use in our patients. The cell population that we use in freshly harvested tissue, bone marrow or adipose, very different from culture expanded cells that have been prepared in the laboratory. And so, as mentioned, the term MSC should only be used to refer to a culture expanded population of cells that meet these criteria from the International Society for Cell Therapy. It should not be used to describe these heterogeneous populations of native cells that really have undefined properties in vivo. There's little evidence to suggest engraftment of injected cells. That is, that the cells we inject, very little data to suggest they actually interculate into that tissue there. Again, back to the current paradigms, they work via a paracrine mechanism by producing these various signaling molecules. Furthermore, it is not known if the multilineage differentiation that we know occurs in vitro. I showed those little charts earlier, those graphs of the cell becoming lots of different cell types. Well, that happens in culture. We don't even know if that happens in the in vivo environment after transplantation. So here's that diagram again. We don't know that happens. This is well established in the laboratory. Very little data to suggest that cells we implant go through this differentiation pathway in the body. Also understand that the current regulatory environment in this country prohibits cell sorting and culture expansion of these cell therapy formulations. Again, the FDA, the current regulatory environment doesn't allow us to do this. Again, we need to distinguish these cell populations that are freshly harvested from native tissues from culture expanded cell populations. We can't take these cells out of the clinic or operating room and do any type of manipulation, such as cell sorting or culture expansion. Certainly, culture expanded populations, that's a very, that's a highly selected and cell population and fundamentally different from the mixed starting population of cells that contribute to their generation. So again, the cells we use that are freshly harvested is very different than laboratory expanded cells. Furthermore, these heterogeneous populations that we currently use are frankly poorly characterized. The identity and really the biologic activity of these cells is typically largely unknown, and it's recognized that this field needs sentinel markers of cell purity, of potency, of their biologic activity to really characterize what it is we're putting into our patients. All of this would suggest that tissue regeneration via cell therapy, again, it's quite unpredictable. Again, we can modify symptoms, but truly regenerating tissue, we're not quite there yet. And a critical limitation at this time is the heterogeneity in these cell populations. We have a very rudimentary understanding of these currently used therapies. We need reproducible methods to measure and classify cell therapy various autologous blood products. Again, as mentioned, this heterogeneity is what points to the need to identify sentinel markers of activity, purity, potency, in all of these different formulations. If we could characterize cells, that would allow the ability to remove competing or inhibiting cells, which would allow much more targeted therapies, which can improve our clinical outcomes. To this point, there's a paper published 5 or 6 years ago, which outlined these minimal information for studies evaluating biologics and orthopedics, all the factors that we should be recording in our clinical studies, such as, where the cells come from, how are they processed, how are they injected, all the important data that we need to help really move this field forward so that we can start to compare these studies. And I've written some editorials in this area, and one I wrote here a couple of years ago, and the need for minimum reporting standards, that it's kind of put in a quote. And one of my conclusions here is that the adoption of minimum reporting standards that facilitates the characterization of these therapies, that could bring us closer to a personalized medicine approach for our patients. And this whole, personalized medicine area makes very good sense, and in any area of medicine, but no more so than in this whole area of regenerative medicine, where there's such heterogeneity in these various formulations. To kind of summarize where we are here, we kind of determined here and explained that biologics can be symptom modifying, but little evidence to suggest that they truly are structure modifying. Again, these products, whether it's blood products or cell-based therapies, can improve symptoms. We've established that they work via this paracrine signaling, with very little evidence that these cells really will achieve long-term engraftment or even survival into the tissues after we inject them. Very little evidence to suggest that these therapies affect the tissue microstructure, composition, or material properties. Again, they act via production of varying signaling molecules, which are very important. There are various cytokines, chemokines, a number of anti-inflammatory and immune modulating proteins produced by these materials that can have both anabolic and catabolic functions. But this also points out the tremendous heterogeneity in all the proteins and molecules, signaling factors produced by cells are complex. And my cells are different than your cells. So everybody's until we can characterize what we're putting in a patient, it makes it difficult to truly carry out studies until we really characterize what it is we're putting into the patient. Another important factor is in using all of these biologics, we have to ask ourselves, what are we trying to treat? What is the goal? What is the biologic target? Do we want to increase tissue vascularity? Perhaps. Do we want to stimulate cell migration? Maybe decrease inflammation? Maybe accelerate matrix remodeling? Perhaps just attract local or even distant progenitor cells? We may want to decrease the degradation of the initial blood clot that forms in tissues that supports healing. Maybe we simply want to affect the production of pain mediating, these nociceptive mediators, these chemicals that mediate pain. All of these are important and relevant biologic targets, but they're all different. Identification of the desired target may ultimately allow us to match a specific either PRP formulation, a cell formulation, etc., to the specific tissue that we're treating. And this requires identification of the underlying cellular and molecular mechanisms of the tissue we're treating. So trying to treat arthritis or a tendon problem or muscle problem, those are all very different. We need to understand the underlying pathophysiology of our tissues. Chronic tendonitis is very different than an acute tendon injury. You may have arthritis, and what we call arthritis is probably 25 different conditions. Sometimes it's a very inflammatory environment, sometimes it's not. At the same time, we need to rigorously define both the composition and the biologic activity of these formulations, and only then could we match the specific agent or treatment with the desired biologic target. Certainly, one size does not fit all. Again, we're getting the concept here. We need to tailor the therapy to the underlying pathology. There's variations in anatomic site that we're treating. It may be an acute process versus chronic process. Systemic metabolic abnormalities such as diabetes may very well affect the biology. And we shouldn't forget the local mechanical environment. These tissues, musculoskeletal tissues, tendons and ligaments and cartilage and bone, all see mechanical load. Mechanical load has a profound effect on the biology of cells, and that's an area that still needs much more understanding. Certainly the same, PRP or cell therapy preparation should not be expected to have the same effect on diverse types of tissue, an acute process versus a chronic process. Sex likely matters, age probably matters. Again, medical comorbidities all will affect the biologic effect or biologic response to these various materials. So I thought with that backdrop about cell therapy, we can consider kind of their role in the treatment of osteoarthritis as an example of a condition that kind of a clinical problem that's obviously widespread, and how might we use biologics in the area of treating osteoarthritis? Well, certainly inflammation plays a critically important role in osteoarthritis. OA is a very complex process characterized by involvement of different cells and tissues kind of listed here. It's not just cartilage, but it's changes in bone marrow, in the meniscus, the synovial membrane in the joints. It's very, very complex. It's become clear that innate immune cells, macrophages, mast cells, and other innate cells play critically important roles in the early inflammatory response in the setting of early arthritis. And then adaptive immune cells also contribute to the development of a chronic relapsing course of inflammation. And we'll kind of explore a little bit here about the interaction between cell therapy that we can do with the local immune cell populations that play such a critical role in osteoarthritis. To even start to talk about inflammation, we have to recognize it's highly complex, and you could have an hours-long lecture just on inflammation, but some high points here that relate to kind of orthobiologics and arthritis. We know that the anti-inflammatory and immune modulating effects of cells, it seems to be context dependent. That is, these cells can actually promote inflammation when the immune system is underactivated, and in contrast, they can decrease inflammation when the immune system is overactivated. So again, very, very complex and probably context dependent. We know that these cells that we implant express a number of immune suppressors that can actually switch the immune cells from a pro-inflammatory phenotype to a more anti-inflammatory or pro-regenerative phenotype. And really, macrophages become central in this process here. The effects of these cells we put in are mediated by polarization of macrophages from this so-called M1 or pro-inflammatory macrophage to a pro-regenerative so-called M2 phenotype. So it appears that these cell therapies act by modulating the local inflammatory environment. And they again produce a number of anti-inflammatory and immunomodulatory mediators, probably not dozens, but truly hundreds. So it's very, very complex to understand the interactions of the cells we implant with local cells, with immune cells. It's just still identifying the various signaling molecules that are produced by the cells that we implant in our patients. We know that MSCs can directly affect synovial inflammation. A number of animal models have certainly demonstrated this. So a number of mouse models have been used inducing experimental osteoarthritis with kind of inflammatory environment in the joint there. It's become clear that activated macrophages in the joint lining contribute to the overall pathophysiology of osteoarthritis. Well, if you use cells, in this particular study, cells derived from adipose tissue, cells can suppress these activated macrophages. These cells can downregulate various pro-inflammatory mediators. They can decrease formation of bone spurs. So these cells can actually have a positive effect on the structure in these joints. It's become clear also that cells we implant are the effect is mediated by cells of the innate immune system. This is kind of a classic paper, this group in the Netherlands, where they demonstrated that systemically administered MSCs, and you can just inject these intravenously, these cells are rapidly phagocytosed by monocytes, and that leads to polarization of monocytes into an anti-inflammatory phenotype. So the cells we inject probably directly interact with and are phagocytosed by monocytes. These primed monocytes then induce upregulation of T regulatory cells, which can lead to induction really of a long-term adaptive immune response as they differentiate into macrophages. So in this way, this data shows that the biologic activity of the cells that we implant may in fact be independent of their cellular activity. In fact, this actually challenges the hypothesis that the effects of cells are mediated by their secretome. Again, back to this medicinal signaling cell concept I mentioned earlier. Maybe in fact, in addition to the cells producing these signaling molecules, they act via, their effects are mediated via innate immune cells, such as monocytes. Furthermore, locally injected cells can in fact have a systemic effect. The neat study, a clinical study in patients with osteoarthritis, they use flow cytometry to characterize the various innate and adaptive immune cell subsets after intra-articular injection of adipose-derived cells. So these 18 patients received cell injections in their joint. They drew blood, and they found that the percentage of regulatory T cells was increased out to at least 3 months in these patients, kind of demonstrated graphically here. The frequency of these T regulatory cells at various time points was increased, so in the circulation. Similarly, the proportion of various B cell populations was also increased, and so these results suggest a global switch toward a regulatory T lymphocyte function in these immune cells after injection, suggesting again that these local injection can in fact have a systemic effect. So these injected cells may in fact initiate a cascade that leads to longer lasting systemic immune modulation in osteoarthritis patients. And maybe this is how they have this positive effect on symptom modulation. And to further explore the role of macrophages in osteoarthritis, again, we know macrophages are the most abundant immune cell type that infiltrates the synovial membrane in the setting of osteoarthritis. And basically, there are two macrophage populations. There are resident macrophages in the joint tissues, and there are monocyte-derived macrophages coming from the circulation. Certainly, in macrophage biology, it's very complex. These cells demonstrating both kind of pro-regenerative and anti-regenerative properties, or anabolic and catabolic functions. And the phenotypic switch between these cells is an area of active research. Again, both pro-inflammatory and anti-inflammatory phenotypes within macrophages. So macrophage biology is very complex. In fact, it's even an oversimplification just to kind of categorize these as anti-inflammatory and pro-inflammatory. We need much more nuanced understandings of macrophage biology. But to kind of summarize sort of what happens in the setting of osteoarthritis, we know there are a number of inflammatory cytokines and proteins that are activated, some of which are listed here. Some of the prototypical pro-inflammatory cytokines, such as IL-1 beta, TNF alpha, that these factors attract these circulating pro-inflammatory macrophages, these M1 macrophages, the pro-inflammatory macrophage. Well, what happens then is these macrophages will perform a kind of a phagocytic function in the joint, but then they begin to secrete anti-inflammatory mediators. As I mentioned earlier, how macrophages and cells can be very context dependent. So in a pro-inflammatory environment, now the cell begins to have more of an anti-inflammatory phenotype and secretes these anti-inflammatory mediators. That then leads to polarization of these macrophages more to this anti-inflammatory or pro-regenerative phenotype. It's probably failure of this orchestrated response within the joint, this M1 to M2 transition. Failure of that, or failure of resolution of inflammation, that's probably leads to chronic inflammation, and that's what can contribute to eventual osteoarthritis development. So we know inflammation is part of wound healing, part of response to injury. That's probably a good thing, but it's when inflammation fails to resolve and it becomes chronic, that's what can contribute to diseases and pathology. And that's a general concept that goes certainly beyond just our osteoarthritis. So again, we know that the implanted cells can enable this phenotypic switch from a pro-inflammatory to this anti-inflammatory mechanism here. And the molecular mechanisms, they're very complex. And this diagram kind of gives you a sense of what happens here. And there's a number of different cytokines that one can go into. But for the sake of discussion, the kind of the overall view is that these cells release a number of these mediators that will go from and induce change from this pro-inflammatory macrophage. We put in cells and they become this anti-inflammatory phenotype here. In fact, it's the extracellular vesicles, the exosomes derived from cells that can transport all these different molecules. And these molecules often can't be secreted. So the exosomes, or these vesicles, can transport these molecules and lead to this positive effect here. And it's these extracellular vesicles derived from cells that have been shown to promote this anti-inflammatory macrophage phenotypes. This is where a lot of the research in the field is currently trying to understand how we can change these macrophages or induce polarization to this pro-regenerative or anti-inflammatory phenotype here. So kind of start to finish up a little bit here. What does this mean for us as clinicians? A lot of basic data there about cell function and cell therapy and how these cells might act. Well, some clinical studies certainly support that cells can have a positive effect on the symptoms of knee osteoarthritis. This particular study here, 12 patients with knee OA received a single injection in the knee of 1, 10, or 50 million cells in this phase 1 trial. They found no real adverse events here. They did report improvements in a number of patient-reported outcome measures, kind of standardized outcome measures. You can see at the bottom of the graph here, the red line is a 50 million cell dose, improvements in some of these standardized scales. So there is some, the ability to improve symptoms, a number of other studies to support this as well. Another group here, they carried out MRI scan in these patients here to look at the cartilage in these patients here. And what they find is the synovitis score does kind of change over time. So the MRI can look at the degree of synovial inflammation here. Collagen content did not really change over time, but various cartilage catabolic markers and against synovitis score were in fact impacted at the higher doses here. They also found that a panel of anti-inflammatory markers was checked, and that was found to be strongly predictive of the patient-reported outcome measures. So the ability to kind of use these blood tests to kind of help predict a patient's response. This data provides a potential to have a predictive donor selection criteria that could be useful for us in further studies in this area. So some ways to kind of understand, kind of predict a patient's response to cell therapy. A nice study from a colleague of mine in Japan where they took patients knee osteoarthritis and they carried out intra-articular cell therapy injection. All patients had failed a prior steroid or so-called gel injection, hyaluronic acid. They compared either culture expanded adipose-derived cells or non-cultured stromal vascular fraction cells. So two different formulations, both derived from adipose tissue. They looked at the patients at 6 months. And in fact, both groups reported improvements in symptoms and some of the various patient-reported outcome measures. Symptom improvement was better. The symptoms improved earlier and to a greater degree in those patients who received the adipose-derived cells, the cultured cells. So clearly there's some data to suggest that cells can truly have an effect on symptoms. They concluded that these cultured cells outperform the non-cultured cells in the early reduction of symptoms and pain in the setting of knee osteoarthritis. A number of meta-analyses further support the positive effect of cells in symptomatic improvement in knee OA. Just to kind of go through a couple of meta-analyses here. This is a particular one that included 15 different randomized controlled trials and some other studies, over 500 knee OA patients. And the conclusion is there's improvements in visual analog scale scores. You can see that the forest plot here for the visual analog scale. Another systematic review or meta-analysis of 9 randomized controlled trials. Again, significant improvements in visual analog scale scores, as well as other validated patient-reported outcome measures that measure symptoms in knee arthritis. So again, good data to support symptom modification. But again, as mentioned, can these cells do more than treat symptoms? Can they, in fact, regenerate tissue? Can they be structure modifying? Well, and no doubt the allure of stem cells is the potential for generation of structurally and functionally normal tissue. And this is based on, again, this demonstrated multilineage differentiation potential of cells in vitro. But at this time, really just limited evidence for true tissue regeneration by these implanted cells, and limited evidence that these cells will intercalate into host tissues, and again, and directly differentiate into healing tissue, as mentioned earlier. We can consider briefly when I talk about tissue regeneration. How does tissue regenerate? Well, certainly it's very complex, but we know that tissue regeneration in the adult mammalian tissues is orchestrated by the immune response. Again, very complex interaction of immune cells with local tissue cells. But again, back to macrophages, they play a critically important role in tissue regeneration. We know that neutrophils and various pro-inflammatory macrophages will infiltrate the joint in response to cartilage damage or cartilage injury. In inflammatory environment or arthritis, we have, we see these pro-inflammatory macrophages, which then again secrete various anti-inflammatory mediators and can induce polarization to this anabolic M2 phenotype. But ongoing tissue injury or ongoing cartilage damage, that's what leads to prolonged or unresolved inflammation. And that can lead to either certainly fibrosis or stiffness in the joint, and really go down the fibrosis pathway rather than regeneration of functionally normal tissue. So regenerating phenotypically normal tissue has proven to be a real challenge so far. And that gets us back to the intrinsic stem cell niche. Again, it's established that many tissues harbor a population of intrinsic progenitor cells. I mentioned earlier, these are cells that reside in the walls of blood vessels. These are probably termed pericytes. Many of these cells express the CD146 marker. It's become clear that the cells that we implant, exogenous cells, produce these signaling molecules that then stimulate these intrinsic progenitor cells. And it's probably these intrinsic cells that in fact may initiate tissue healing and regeneration. So the ability to regenerate tissue probably is there. Well, it comes from these intrinsic stem cells. It's probably the factors that we put in, these cells from bone marrow or adipose tissue or anything else. It's probably the factors that produced by these exogenous cells that stimulates the intrinsic stem cell niche. So the potential for cells to induce tissue regeneration, again, is due to stimulation of these intrinsic stem cells that we know are resident in many tissues. Are there any data to suggest that stem cells may be structure modifying? Well, in fact, there are a number of preclinical animal studies that do support this contention. Some mouse models of EOA have been used. In this one particular study, they injected adipose-derived cells 7 days after induction of osteoarthritis, and they found that cells, in fact, inhibit inflammation. They inhibit the synovial membrane changes. They inhibit osteophyte formation, and in fact, inhibited cartilage damage. So the cells can, in fact, be structure modifying in this particular model. Another animal study here is a rat model, a knee osteoarthritis model, where they cut the anterior cruciate ligament to and destabilize the meniscus in order to induce some arthritis. And then they inject bone marrow-derived cells here. And they compared not just bone marrow-derived cells, but the exosomes derived from bone marrow cells. And both of these, the cells themselves or the exosomes, in fact, alleviated cartilage destruction and the subcondylar bone remodeling that is seen in osteoarthritis. So the graph at the top there, you see OA is in red, and the other two, exos and MSCs, that's the exosomes and the cell therapy, certainly a much lower osteoarthritis score there. And they found reduced joint damage, improvements in bone parameters as well in these animals. They found that cells derived from bone marrow exert these beneficial effects probably by reducing cell senescence and reducing apoptosis of chondrocytes. So, the death of cells in the joint. So these cells certainly can have a positive effect even on the structure in the joint. But what about moving to clinical studies eventually here? Here's one more model, another mouse model. This is a classic study from Stanford University. Michael Longacre's done a lot of nice work in this area. Again, a mouse model where they use microfracture, which is a commonly used surgical technique. We drill small holes in the bone to kind of try to induce some tissue healing. Well, they found when they did that in the mice, just like we see in patients, some proliferative tissue forms in the joint surface. You can demonstrate proliferating cells there. They found that there's an expansion of a local stem cell population that contributes to this regenerating fibrocartilage tissue. And in fact, when they went ahead then and delivered various important cytokines, BMP2, as well as vascular endothelial growth factor, then when they delivered these factors, that skewed differentiation of these skeletal stem cells more toward articular cartilage. We see at the top here the graph for aggrecan and collagen 2, two important proteins and molecules in the cartilage matrix were kind of turned on by or stimulated by these various cytokines. You can see that here. Histologically, cells, the animals treated with these particular cytokines had improvements in formation of collagen 2 and aggrecan, so more of a hyaline cartilage phenotype. So these data indicate that following this commonly used procedure, microfracture, there is a resident stem cell population that can in fact be induced to generate cartilage in focal cartilage defects. So again, demonstrating the potential to regenerate some tissue here. And then turning to human clinical studies in this area, we've some data out there. Is in particular study here carried out intra-articular injection of cells derived from adipose tissue in patients with knee OA. The cells were cultured for 3 weeks, and this particular group did a nice job of really characterizing the cells. Before they injected the cells, they characterized the cell number, the cell viability, the purity based on various cell surface markers, obviously sterility, and basic safety markers that need to be evaluated, such as endotoxin and mycoplasma. So a small study, 18 patients. They found that clinical scores improved at 6 months after injection, but importantly, objective evaluation using either MRI or arthroscopic inspection demonstrates distinct improvements. The size of the cartilage defect decreased and the volume of cartilage increased on both the femoral condyle and the tibial plateaus. You see these arthroscopic pictures above here. And in fact, biopsies demonstrated that this regenerated tissue demonstrated a kind of cartilage-like property. So some data here to support actual tissue regeneration with these. These are culture-derived cells. It's from a group in Seoul, Korea. So the potential is there for cell therapy to actually regenerate tissue. Another study from a group in Spain, a randomized trial where they use culture-expanded bone marrow-derived cells. And the control patients receive these gel injections, hyaluronic acid injections. In fact, patients treated with cells displayed significant improvement in functional indices versus controls. But importantly, using an MRI scan with some quantitative MRI techniques such as T2 relaxation time measurements, they found a significant improvement in cartilage quality in the cell-treated patients, again, suggesting the ability to actually modify structure and not just symptoms. But again, this is culture-expanded cells. What about what we can do here in the United States? Well, nice study from my colleague Shane Shapiro down at the Mayo Clinic in Jacksonville, Florida. Kind of a neat study. This is a single-blind, placebo-controlled trial where they use bone marrow aspirate, just like we can do, currently here in the operating room or even our clinics. Single-blind trial. What they did is these is 25 patients with bilateral knee pain from OA. So they randomized to receive bone marrow in one knee and saline in the other. What they found, and again, these cells are not culture expanded. This is kind of the current techniques we can use in the operating room, where we can do a bone marrow aspirate and then centrifuge these cells over 15, 20 minutes, concentrate the cells, and then inject them. In fact, the outcome scores improved in both knees, and interestingly, no different, which kind of demonstrates the strong placebo effect. So both groups got better, but the cells were no different than saline here. Similar pain relief. They went on these patients and used MRI at 6 months to kind of look at the cartilage. And using some of these quantitative MRI techniques, there were no changes post-treatment. So these cartilage sequences failed to show any real regenerative benefit with a single bone marrow injection. So the mechanisms of action that led to pain relief are certainly not due to cartilage regeneration in these patients here. So to conclude here, I would submit to you, I think we've shown that we really currently have very little ability to use true stem cells as defined by any formal cellular or molecular criteria. However, I think cells that we've shown can be symptom modifying. Cell therapy holds tremendous potential for treatment of symptoms of knee OA, acting via this paracrine effect, where the cells can modulate the local tissue microenvironment by producing a number of these anti-inflammatory and immune modulating factors. Clearly, cells interact with local immune cell subtypes in the joint. MSCs, we've talked about how they play an important role in macrophage biology and macrophage polarization. The other side of that coin, again, can cells be structure modifying? Well, there certainly is a potential for tissue generation. In the future, cell sorting techniques to allow us to select the desired cells and then culture expand those cells, that will really help us move this field forward and provide the ability to potentially regenerate tissue. But again, we need to identify markers of cell purity, cell potency, cell biological activity in order to allow both characterization of these cells and selection of the desired or optimal cell populations. Tissue regeneration may ultimately occur via stimulation of the intrinsic progenitor cells that we know are already resident in many tissues. And lastly, my own view on the future approaches here, some thoughts to kind of finish with. Clearly, the heterogeneity in the starting material for cell cultures, that suggests to me that some elements of the cell population may be desirable for the specific tissue or pathology being treated, while other cells may, in fact, have the potential, may not have the potential. They may, in fact, be inhibiting. So we need to be able to select out the cells we want. And these, there may be cells that may compete with or inhibit the desirable clones in a given cell population. So we need development of methods to reproducibly characterize population of cells, and that could eventually allow us the ability to remove these competing or inhibiting cells. Certainly then, cell sorting techniques can be used to select a desired subset of cells based on specific criteria, eventually allowing a much more precise match of the cultured cell population to the pathology or tissue being treated. And the ability to match the cell population, or for that matter, PRP formulation, to the desired biologic target would ultimately facilitate, again, this precision medicine approach to treatment. And I'll stop there. Thank you.
Well, it's a perfect way to close this, Dr. Rodeo. Thank you so much for spending time with us today, giving us your expertise, and we're very grateful and appreciative. Thank you.